Medurstand. Understanding medicine.
Professor Azizur Rahman here. We are discussing the role of imaging in lung diseases and heart diseases. And today we are going to talk about the radiology in heart. Most of the discussion will be about X-rays, the conventional imaging technique, but I will be touching upon some modern imaging technology also, just to complete the module. Now, the first thing which we want to see in any X-ray about heart is its size. If the size is normal or enlarged, enlargement of heart is a sign of many diseases. Like pericardial effusion, cardiac failure, various chamber enlargements. So I think it's a very common finding in many conditions. So we are very interested to see if the heart size is normal or not. In this case, it is massive cardiomegaly. You actually don't need to measure it formally, and it is so obvious. But in the examination, you would be required to actually precisely measure it and demonstrate how to determine the size of the heart. Now, I'm going to demonstrate that now. First of all, you draw two lines. They are imaginary lines. You may actually draw the lines, but that will spoil the X-ray. So I think just imaginary lines. And these lines correspond to the internal thoracic diameter. So they should be chest cage, bony, internal thoracic bony diameter. So they should be, this is the chest cage. This soft tissue should be excluded. So wherever you have the maximum diameter, and that part may actually be below the diaphragm. So in this case, this part has got the maximum transverse diameter. So I have drawn two lines. And then we draw another line which is in the center. So this would divide the maximum thoracic diameter into two halves. Now let's now do the same with the heart. We draw two vertical lines corresponding to the right cardiac border and the left cardiac border. So these are the lines, and this corresponds to the most convex part of the right cardiac border, and this one most convex part of the left cardiac border. And the distance in between is the cardiac diameter. So maximum transverse cardiac diameter should be less than half of the maximum internal thoracic diameter. So in that case, this should be less than this. It should end before this line. In this case, it is clearly more than half. So it is very, very obvious and massive cardiomegaly. At one point, it is perfectly possible to have a fairly advanced disease with normal heart size. And it is also possible to have somewhat cardiomegaly due to non-cardiac condition, and that may be called pseudocardiomegaly, and the heart may be normal. So you need to be watchful. Cardiac enlargement is one of the features of the heart diseases. The second thing, after size, in this case, if you measure formally, I'm sure you will agree that this is also cardiomegaly, not that much as we saw in the last section, but there is definitely cardiomegaly. And the second thing we want to know about the heart is its silhouette, the shape of the heart. Now, if you know, this is not the normal shape, because normally this border should be concave. Normally this is the aorta, and this should be concave border like this, and then there should be left ventricular convexity. In this case, this concavity, there should be concavity here. This concavity has been replaced by this convexity. So this cardiac border is unique cardiac border, and this cardiomegaly is called mitralization of heart. Why do we see mitralization? Because this kind of morphological abnormality we see typically in mitral stenosis or mitral regurgitation. In mitral stenosis or mitral regurgitation, you have enlargement of pulmonary artery and left atrium. They cause this convexity, and there is also enlargement of right ventricle and right atrium. They cause this enlargement of the the cardiac border. This is typically described as mitralization because it is typically seen in mitral valve disease, but actually it may be seen in other conditions also. In pulmonary hypertension, for example, in atrial septal defect, in ventricular septal defect, that the morphology is not very different. Now, if you see the trachea, I think this is a very interesting finding, and if this is the trachea, and this is the left main bronchus. Now, if you agree, this is also somewhat lifted. Normally, the left bronchus should come like this, like this. It is somewhat lifted, and this is again a sign of left atrial enlargement. The left atrium is situated here on the back side, and that has lifted up the bronchus. So this typical shape is mitralization, very typical of mitral valve disease. This is another case of cardiomegaly, although it is not as impressive as you saw in the another X-ray, but this is definitely cardiomegaly. You can measure, and I think right heart is particularly prominent, but lung fields are clear. I don't see any effusion, and left hemidiaphragm is slightly elevated. So I think I would consider cardiomegaly, and then based on clinical features, the murmur, I would make a definitive diagnosis. In any case with cardiomegaly, if you see on X-ray, the definitive confirmatory test would be an echo. Echo will not only confirm if there is cardiomegaly, it will also tell you what is the cause of cardiomegaly. This is another case of cardiomegaly, but there is actually another problem, and you see, one thing is the cardiac border is not as sharp as there was in the earlier X-rays, because there are two pulmonary shadows on both sides. But if you can see this one, this is opacity, which is not as dense as heart, but it is denser to the hilum side, and as it diffuses out, it becomes faded. Similarly on the right side. And additionally, you have this transverse fissure, which is, there is some fluid in transverse fissure also. So cardiomegaly with these kinds of infiltrates should suggest the possibility of pulmonary edema. Pulmonary edema may be a symptom or sign of biventricular failure, left ventricular failure, cardiomyocarditis, or it may also be seen in non-cardiac conditions like aspiration pneumonias. So this is, I think, as far as X is concerned, I would read it as cardiomegaly with pulmonary edema. I think if clinical features are those of heart failure, I would, I think, take this X-ray as confirmatory. This is another patient with even denser shadows. I think they are very typical, just like the previous one, but there are two differences. Number one is that these shadows are much more denser than the previous one. And number two, heart size is not large at all. So if you have normal heart size but you have pulmonary edema-like picture, you may suspect non-cardiogenic pulmonary edema, or bilateral pneumonia is also a possibility. As you can see, these lines and catheters and electrodes, I think this patient must be very sick, and there is perhaps an endotracheal tube also. Maybe this is a case of COVID pneumonia, but the appearance is very much similar to pulmonary edema. That is why this X-ray is included here. So you need to differentiate cardiac pulmonary edema from non-cardiac pulmonary edema. Now, another thing, you are of course interested to know the cardiac size, but cardiac shape is equally important. Sometimes cardiac shape is so typical of a specific disease that you can actually make a diagnosis. Now, in this case, there are two or three important points. One, the left cardiac apex is somewhat lifted. Normally, this is the cardiac apex. It should be here. Normally, left ventricle is like this, and cardiac apex should be here. And in this case, it is lifted. Number two, the normal concavity in the upper part of the left cardiac border is more pronounced. It is more concave than normal, as if the structures which are normally present here, pulmonary artery and left atrium, they are smaller. Maybe they are smaller in some condition. So I think that is another finding. And the third finding is the prominent right cardiac border. So all these things, all these three observations, and cardiomegaly also, lifted cardiac apex, more concave upper left cardiac border, prominent right cardiac border, and cardiomegaly. I think these are typical features of boot-shaped heart. And now if you look at it, and it would definitely give you some impression of boot. Now this is a feature of Fallot's tetralogy. Fallot's tetralogy is seen in adults also, and this is relatively a grown-up child. The actual diagnosis comes from echocardiography, but X-ray tests can also give you some useful clue. Another case, again, most probably mitral valve disease. You see the prominent cardiac border, left cardiac border, normal convexity is replaced by this convexity, and otherwise lungs appear to be normal. So I think I would again suspect some cause of left atrium or pulmonary artery enlargement, maybe atrial septal defect, maybe ventricular septal defect, maybe patent ductus arteriosus, maybe mitral valve disease. All these conditions can be considered in this kind of X-ray. This is obviously a very sick patient. You can see the pacemaker. You can see the pacemaker lead going all the way to the right atrium and right ventricle, and this is the right ventricle. And you can also identify the prosthetic valves. This is the aortic valve, and this is mitral valve. From their location, one can tell that these are both prosthetic valves, and this is mitral and this is aortic valve. You can also see the metallic stitches of open heart surgery. So, and massive cardiomegaly. So I think all these features are obvious on this X-ray. This is another patient, very obvious cardiomegaly. I think that you don't even need to measure. Right cardiac border is very, very prominent, and lungs are relatively clear. So you could consider pericardial effusion, you could consider dilated cardiomyopathy, you could consider left ventricular failure leading to biventricular failure due to ischemic heart disease. So all those conditions are possible. You know, X-ray is just an image. So you cannot make 100% accurate diagnosis without knowing history. In some cases, it may be possible if the X-ray shows very typical image, but in most cases, X-ray just actually helps you to reach a diagnosis which you otherwise suspect on the basis of your clinical findings. Now, this is very typical globular heart, cardiac enlargement, and you know, the cardiac border is very, very sharp. Not only there is cardiomegaly, not only there is a globular shape of the heart, you do not recognize the normal structure. You don't see the aortic knuckle, and the left cardiac border is of different shape, because this shadow is actually not made by the heart itself. It is made by the fluid around the heart. And fluid, of course, will make a balloon-like thing. So this is very typical of pericardial effusion. You need to have fairly large amount of pericardial effusion to have this kind of X-ray. I think very, very typical. Lung fields are very clear, because in pericardial effusion, you don't have pulmonary edema. Mostly you don't get pulmonary edema in pericardial effusion, because there is the right ventricle is also not receiving blood because of the increased pressure in the pericardium. Right ventricle is not receiving blood, and it is not pumping into the lungs. And left ventricle is not pumping out of the heart, so out of the lung. So there is no pulmonary congestion. In left ventricular failure, when right ventricle is pumping blood into the lungs, whereas left ventricle is not taking it out, that is where the situation when you get the pulmonary edema. So no pulmonary edema, massive cardiomegaly, and typical globular heart. This is pericardial effusion, and the final confirmatory test would of course be echo. And echo would also be needed because this patient might need paracentesis. So another thing is the cardiac location, whether heart is present in its normal position or not. Now this case, you can see this is labeled R, so this is the right side, and you see the right, this is actually a dextrocardia. You see it's a complete dextrocardia. Aorta is on the right, this is the aortic knuckle. You can see the descending aorta, aorta is on the right, left ventricle, functionally left ventricle is also on the right, and you see the stomach bubbles are also on the right. So this is a case of situs inversus viscerans. All viscera are situated on the opposite side. This is liver, this is stomach. So this is so-called left ventricle but on the right side. So dextrocardia, an easy diagnosis. But whenever you see this kind of X-ray, you must make sure the label is correctly placed. So actually a normal X-ray, if you rotate it like this, then it will look like this one. Another patient, there are 2 or 3 abnormalities. One, the metallic stitches. That means this patient must have undergone some cardiac surgery, maybe coronary artery bypass grafting or some other valvular procedure. But this is the ring, and I showed you earlier, this is the ring of mitral valve. So this patient probably underwent mitral valve replacement. And then there is some right-sided pleural effusion also. So this is another very interesting X-ray. You can build up the whole story on this X-ray. Now this is a patient. You see this is pulmonary artery. If you trace left cardiac border from above downward, this is the aortic knuckle, and aorta goes this way. But then under the aortic arch, you have pulmonary artery. Normally pulmonary artery is much smaller, and there is actually a concavity here like this one. And below pulmonary artery, there is left atrium. In this case, main pulmonary artery is dilated. So it is very, very prominent. Right pulmonary artery is seen as end on here. So this is the right pulmonary artery, a large pulmonary artery. I think maybe the main, yes, it is the right pulmonary artery. So both are dilated. So it may be a case of pulmonary hypertension. Another case of pulmonary hypertension, I think in this case, right pulmonary artery is much more prominent, and main pulmonary trunk is also prominent. Still another one, pulmonary hypertension. You can see this is aorta, this is pulmonary artery which is dilated, and pulmonary artery may be prominent in many conditions. Number 1, in ventricular septal defect. Number 2, atrial septal defect. Number 3, patent ductus arteriosus. And number 4, primary pulmonary hypertension. Number 5, pulmonary hypertension secondary to some lung disease, and pulmonary hypertension due to pulmonary embolism. So there are actually other causes also. So all these conditions would cause similar kind of shadow. Now we have discussed common cardiac conditions, and we have discussed the X-ray, but there's another test, another imaging test, that is coronary angiography, and very popular. So I will just take a short, I think, view on this because it's very important. There are 2 types of angiographies. One is catheter angiography, where catheter is passed into the artery, either from the radial or brachial or femoral artery, and the catheter goes right up to the aorta and then in coronary arteries, and the contrast is injected and the image of coronary artery is taken. Now this is considered to be final investigation to rule in coronary artery disease. Very important. I think just appreciate this sentence, to rule in. If you clinically suspect this patient has coronary artery disease based on symptom, based on ECG, or based on whatever cardiac enzyme. So I think if the suspicion is that of coronary artery disease and you want to confirm it, the best test is catheter angiography. And one advantage of catheter angiography is that it also offers therapeutic intervention. You could do percutaneous coronary intervention like stent placement, and it is a relatively major procedure compared to another type of angiography which I am going to show you just now. And you need contrast. So if somebody has increased creatinine level, that patient may not be a right case and there would be a problem. As compared to catheter angiography, there is something called CT angiography. Now this is relatively new technique. With advancement in CT, with the availability of 64 plus slice CT scan, it is now possible to image coronary arteries also. Final investigation to rule out coronary artery disease. Now, if, for example, if you are taken the history and you feel that this is not coronary artery disease, this is not angina, this is not ischemic heart disease, but for some reason you need to rule out coronary artery disease, you may opt for CT angiography. But if the suspicion is more like that this patient has coronary artery disease, then the choice should be catheter angiography. Because in CT angiography, if you find coronary artery disease, there is no possibility of intervention. You would then the patient will have to undergo catheter angiography. And it is a relatively minor procedure. So minor that patient can actually go to the facility, just drive himself and have the procedure, come back. There is no problem because no anesthesia is given. Usually there is no complications. It's a relatively minor procedure and you can determine coronary anatomy and also the presence of calcium. And I'll show you, if CT angiography is normal, that is a great test to rule out coronary artery disease. But if it is abnormal, then usually catheter angiography would be needed. Contrast is required in this also. Now just few images. This is the normal anatomy of coronaries on CT angiography. You see this is the aorta and you see this is the right coronary artery, very nicely outlined, and the branches. So no stenosis, maybe this one, there is little stenosis here in the arrow, but otherwise this one is okay. On the other side, this is the left main, very short left main, and then there is left anterior descending artery, and you have left circumflex artery and its branches. So how nicely you can see all these branches on CT angiography, and all are normal. So if you have CT angiography and you see these kind of vessels, the coronary artery disease can be ruled out mostly. And one thing which we see on CT angiography is the presence of calcium. These plaques are calcium. Normal arteries should have no calcium, but if you have these calcium plaques, they would indicate the presence of atherosclerosis with calcification. And of course, this patient would need a proper angiography if you have calcium plaques. As compared to CT angiography, these are the images of, I think this one is, I'm not sure if this is CT angiography or catheter angiography, but this is the lesion. I think this is CT angiography. Yes, CT angiography. You can see this is coronary narrowing, and this is the conventional angiography. You see it here. And I'm going to show you one more. This is typical appearance of normal angiography, catheter angiography, and you see this part. This is normal, and you have a big narrowing, or think about 90%, and then you have a normal. So this would be an indication for stenting or bypass surgery. I think stent probably in this case. Another image showing conventional or catheter angiography, there are multiple lesions. You can see the narrowing here and you can see the narrowing here. So of course, I think this much is enough for the angiography, but last slide I'm going to show you on this thallium scan, which is again a great imaging test. Now, this is a kind of test which is done in those patients where you suspect ischemic heart disease, but it is not sure. Like it may be considered equivalent of exercise tolerance test. Patient is asked to do exercise and usually on a ergometer, and once patient has achieved the maximum exercise limit, contrast, this radioactive substance is injected. This is radioactive thallium. The thallium is taken up by the heart. So this is the heart image that various views. I'm not going to go into the details, but you can see, just imagine left ventricle. Imagine the rest of the heart is not there. So if you're looking at this side, this is cardiac apex coming back. This is anterior wall, cardiac apex and the septum probably. And this is another view, and this is the cut section, transection section. So all are outlined very well. After patient completes exercise, then patient is given some rest. After a few minutes, then the image is taken again. And in this case, there is no change because there was no ischemia here. So contrast, this radionuclide substance was taken up by the entire myocardium here, and the same image is shown here. But if there is coronary artery disease, you don't see coronary arteries here, but you see the ischemia. Now this part is not as outlined as these parts. So this part is ischemic. And on this case, and this part is ischemic. You can tell that this part is not as, the color is different as compared to this one. So this part where my cursor is ischemic. And in this cross section, this part is ischemic. So at the peak of exercise, these parts do not get blood supply. That is why these parts do not show this radioactivity. Now, if we repeat the test, this radioactivity is already there. Now we repeat the test after a few minutes. Now see, it has now redistributed. Although there is coronary narrowing, but coronaries are still giving some blood, because with some time the ischemic myocardium is also now perfused. Now this scan would show that there is ischemia, and this would confirm that this ischemia is reversible. So you got a very, very useful information that this patient has got reversible ischemia. That means this patient can benefit from any kind of revascularization procedure. Most probably this patient would need a proper angiography and maybe percutaneous intervention or maybe grafting, but this is a very important sign. Now if there is a defect like this, but that persists after 5-10 minutes, you repeat the scan and this defect persists, that would mean that there is ischemia, but it is not reversible. Probably there is complete occlusion of the artery, and there is almost complete necrosis, the fibrosis or scarring of the myocardium. There is no point in doing a revascularization procedure. Thank you very much. This completes this module on imaging on heart. I hope you found this video useful. I'm really looking forward to see you in my next module. Thank you.